I do want to recognize Marie and Nick and Preston. Thank you guys so much for hopping on so far. I'm sure more will be hopping on in just a moment. I do want to take a minute to just thank all the community members and people that help to make these webinars happen, that support it with these Southeastern Washington Economic Development Association, the Pullman Chamber of Commerce, the Small Business Development Center with Aziz Makani, and of course the city has been pushing this out and promoting it too, and we'll be getting the recording done as soon as we can. We're going to do a couple different things with the recording. It's going to be higher quality. We're also looking at doing a transcript so that if people, hey, maybe I don't have enough time or maybe I'm a little bit zoomed out, there's a transcript that will be available for people to read through and see. But thank you so much, Dr. Jones, for being willing to come and help and sit with us and tell us about your incredible business and the business model. We were talking about it a little bit beforehand, but I'll have you introduce it. But if you guys haven't met Dr. Jones, she is absolutely wonderful. I highly encourage you guys to visit her and learn about better care, proper care. And I say proper just in that communication. My folks have been going through a lot of, they're getting older, and it's been hard. And we love the doctors in Pullman overall. Sometimes just computers don't work. And sometimes we just want to talk to a human.
Yeah, well, thank you for having me. Thank you for thinking of me. I appreciate all the effort that goes into trying to support our local communities here. So thank you for that. So I opened Dawn.md, which is a direct primary care clinic, in September of this year. And it's the only clinic in Pullman that aligns our profits with outcomes. So rather than aligning our profits with number of patients seen, number of volume of services provided, it's really the only clinic of its ilk in Pullman that instead trusts the patient to choose the product based on the value that they get, rather than us encouraging people to come in to be seen or to have procedures done, etc. So, the cornerstones of the model are accessibility, affordability, and value.
And it's direct to primary care, and all these things sound great. Is this new? Like, is this new in the way we do medical in America, or is this something that we've just missed?
Yeah, I think it's growing. I think practices like this have existed over 100 years ago, kind of went away, and then has reemerged essentially as a solution for that hamster on a wheel fee-for-service medicine model that we're also accustomed to. I think the last time I looked, there were around 3,000 DPC clinics.
Oh, wow.
Yeah. There might be 3,000 DPC providers, but it's certainly still a minority of clinics that run a DPC model. So it's still, I think, foreign to most people, but growing.
Yeah. And so then, and this is a help kind of answer a few questions that I'm sure a lot of people will probably have as they're learning and hearing this. Like, you don't necessarily need insurance to come and visit you, correct?
Well, I think they're kind of two separate questions. I think people should have health insurance, right? The whole concept behind health insurance at its inception is we want some sort of coverage for catastrophe, for the unexpected, the expensive. But I think the reality is the insurance-based model doesn't necessarily provide excellent primary care. And so by actually cutting out insurance billing in my clinic, I'm able to be a lot more accessible to people. I'm able to keep my overhead lower. I'm able to expand my clinic appointment times. We still encourage our members to have insurance. We know that if you end up in the emergency room or you have a car accident or you have a cancer diagnosis, I'm not going to be able to help you with those things, right? But for the 80 to 90% of health services that we do in the primary care clinic, we feel that the insurance actually just adds to overhead, adds to administrative burden, and doesn't actually do anything to help people get better. In fact, it has quite the opposite effect because you're so focused on bringing people into the clinic so you can bill that code, or doing that additional procedure so you can get that additional procedure fee, or prescribing that medication because you have an increased level of complexity and you're able to bill higher for prescribing that medication. You send a consult, so you're able to bill higher because that medical decision making is more complicated. So there's all these things in our system that are aligned with us doing more for patients, but they're not necessarily aligned with us preventing people from getting sick or giving people a little extra time to explain what they're experiencing, or giving us a little extra time to explain why we want them to do A, B, or C and actually improve that compliance.
Yeah. And I think as I'm hearing it, as I'm listening to it, the direct primary care model provides a better conversation for a patient with you directly too. Because in my mind, if I go to the doctor for a preventative care visit, the moment I ask a question, it is no longer a preventative care visit. And then I'm billed for the full thing.
Yes, and you don't have the time to address that thing, right? Because, my previous clinic, we were allotted 45 minutes for our preventative care visits. And, the push was to push them down to 30 minutes. Each time we'd have an administrative meeting, I would have to say, hey, I can barely do a 30-minute physical, much less address the number of things that people are kind of storing up for you at that one visit that they come to you for that year. So I can't stress enough how much of a difference it makes to have a 30 to 60-minute office visit. So right now, rather than having a 15-minute office visit at my previous clinic, I have nothing but 30 or 60-minute visits. And that little bit of extra time gives people that little bit of extra time to ask you questions to make sure that they're confident that you're confident in your treatment plan. And then when they leave that visit, they're not feeling like they need to go get a second opinion. They're not feeling like they don't understand why that medicine was prescribed. Maybe they go to the pharmacy and you've talked to them about the meds and the side effects, but maybe they get a different message from the pharmacist, or maybe the medication wasn't what they expected. That person can call me, text me, email me, ask me clarifying questions. I don't bill them again for that. And because I don't have to worry about not being able to bill them for that time and not worrying about this massive overhead for me to take 10 more minutes to explain to them why I prescribed that medication for them, it really improves their outcome, right? So it allows them to understand what that treatment plan was about and actually comply with that treatment plan, rather than leaving feeling like they weren't listened to or feeling like they need to go find another doctor to get another opinion from.
Yeah, no, absolutely. And I can absolutely see the value in that. My dad's been kind of on a medical journey, and I cherish the time I get to spend with him. And he recently, through doctor's visits and everything, went from like 10 medicines down to 2. And it is a night and day difference for him. But even when he had the 10 medicines or medications prescribed, he didn't know what they were. And he was just like, well, why am I taking all this? What's this one supposed to do, or how? And it was just really hard for him to understand and be able to work through. But then it was just kind of, here you go talk to the Safeway pharmacy or Walmart pharmacy to see what's there. And so then in your model, you're able to just spend more direct time with the individual and make sure that they do understand each of those points. And then they are more likely to take the pills, right? Or is that kind of what you see, or is that?
For sure. Yeah, for sure. I think, to your point about going to your physical and having maybe one or two little things that you want to ask the doctor and not realizing that you're going to get charged for each of those additional questions. But then your doctor's really in a time crunch, right? So they've got to make a decision. Do I spend the time I need to address this rash that this person has and really educate them well and give them handouts and explain to them about the medication? Or do I do the quick thing and write the prescription that I know I can bill for? Or do I send them off to a specialist where they then have to travel, wait several months, incur a $200, $250 office charge? And so it's really not good for the patient, but it's also not good for the doctor, right? And so it's amazing now, these things that I would have had to have referred, or I would have had to just okay, I can try to treat this problem, but I only have 5 minutes to do it or 2 minutes to do it. And now I can say, hey, we're at the end of our 50 minutes, 60 minutes, but it doesn't cost you anything to come back and ask me about that rash tomorrow, or, let me send you some links and some information on this that you can peruse on your own time and then come back to me when you're ready to start a treatment for that. So, yeah, I mean, it makes so much more sense, right?
Well, and it does. And I can also understand people with HRAs, or not HRAs, with health insurance. Our family is on an HSA, so health savings account. And so then low deductible. But if I do take my kid in for like a 15-minute hospital trip, or not hospital, just like a routine visit, oh, hey, he seems to be lethargic or has a cough or whatever, it's a 10-minute, hey, check him. Is he going to make it? Is he okay? And then I get hit for like a $150 bill.
Mm-hmm. Yeah.
Which your stuff is pretty affordable.
It's meant to be very affordable. I mean, so, our prices are 100% transparent. So I think right there, most people are going to save money because they're not going to get that surprise procedure bill or that surprise additional fee for that extra question they asked. We, not only do I have very affordable monthly payment prices, but I also couple that with access to discounted labs and medications. So I have several members that easily make the money back from their membership on the medicine prices that they save through our wholesale pharmacy prescriptions. Wow. So yeah, it's very affordable. And I think, I can't stress enough that just that increased access, like people want me to take care of more things for them because they don't have to pay extra for it. So, I've just recently opened my Rubicon account, which is an e-consult service, which is amazing. It's like the most sensible thing you can do, right? So I can, like I said, I can either, try to treat something quickly in a few minutes, or I can have the person come back and pay an extra office fee, which they almost never do, or I can refer them somewhere for a lot of time and expense to them and a lot of time for the specialist, or I can take a picture of the rash, email it to the specialist, say, hey, this is what I'm thinking for this rash. Does that make sense to you? They email me back within 24 hours. I think this is the diagnosis. These are the 3 things I would do in the treatment plan, and these are the prescriptions I would give. Boom. I just saved that person, 2 to 3 months of waiting to get into a dermatologist, an hour to 2 hours of driving to see the dermatologist, and I've got an excellent treatment plan that I can talk through with the patient. And that's something I would never be able to do in my previous practice because it was all volume driven. It was not value driven. So I pay for that service, but then I'm able to pass that value on to my subscribers.
Yeah, absolutely. So then how has, I guess, medical services, but also your services changed during this whole COVID thing? Because that being able to take a picture of a rash, send it, and have a specialist look at it, like,
yeah, it's
huge. We should have been doing that 10 years ago. Like, what?
Absolutely. And we've always had the technology, right? But we haven't been able to use it because we're not able to get reimbursed for it. I mean, people are begging for this, right? They're calling and saying, hey, I know I just need a referral, or hey, I'm pretty sure I don't need to go to the ER. I'm on vacation. My kid just hurt their head, but I'm not sure. Can I talk to my doctor for 5 minutes? And we're saying, no, because we can't bill for that. We can't offer any medical advice over the phone, right? And so people get pushed into the ER. They get pushed into the urgent care. And the systems love that because that's where they make their money. It's not satisfying as a provider. It's certainly not satisfying as a patient. So yeah, why not use all this technology that we have? Why not use these resources that we have? And, COVID has changed that to some extent because now insurances do allow for telemedicine visits, but, there's still an incentive there to get people on the schedule, to get people on the telemedicine visit. I had a patient over the weekend who texted me and said, hey, I have this thing. Do you have weekend hours? And I said, well, I don't have office hours, but if we can do it via telemedicine, or if you can send me a picture, or if we can wait till Monday, those are your options. And she said, oh, well, I'm just going to send you a picture. And she sent me a picture. And I said, oh, that's, it's likely A, it could be B or C. You might need this test. And she said, okay, well, can you order that test? I said, yeah, I can order that test. If that had been in my previous clinic, that would have all been uncompensated time, right? And as a policy for our clinic, we weren't allowed to do that. If someone called and said, I have a bladder infection, I know it's a bladder infection, I just need an antibiotic, I would be giving up my income to treat that person, right? And of course, there are times when your doctor's going to do that, but more often than not, there's going to be a policy against it. That system that they work for is going to want you to send that person to the ER, the urgent care. So for this patient, I was able to say, oh, that looks like this. I think you need this test, and I think you need this prescription. I was able to send that off for her. I still haven't seen that patient for that problem, but I know that she got equal quality care as she would have gotten if she'd had to go to the urgent care, maybe better because she gets to talk to someone that she knows and whose opinion she trusts, and that she's likely to follow through with that treatment plan. And her treatment plan ended up being watchful waiting, right? Which is often the treatment plan, which is not a very expensive treatment plan. So we make these really simple problems into these really expensive processes.
Well, yeah, and just to me, like the reduction of stress, reduction of anxiety, of just, oh, okay, I know I'm okay, or I know my kid is okay, or I know, hey, it's okay. I mean,
And I think I think most people want to see a provider they know and trust, right? Most people would prefer not to go to the urgent care. They don't necessarily know who they're going to see there. You know, if they have an option of having an established provider, most people would prefer to see that person. And so this model allows for that. You're always going to see your doctor.
yeah, absolutely. And so then, how have you been working with the employees and patients coming in and out of the office? Like, is there set procedures for that? Is it, like I said, I haven't been to a doctor during COVID, so I don't know what new procedures might be there, or if there's something unique that you're doing in that process.
The beauty of a small model is you get to use common sense a lot more than protocols. So, you know, I know all my patients. Many of them followed me from my previous practice. I know their family circumstances. I know their work circumstances. I know whether they're science-minded or more of a conspiracy theorist-minded. And so with that, I largely let the patient decide if they want to come in or not, but I generally try to say, hey, you know, if this is something we can do via telemedicine or via a phone call, let's do that. And people love that. They don't necessarily want to have to come in, but they like to have the option to be able to come in. I also have a lot lower patient volumes, right? Because there's so many things that we go to the doctor for that you don't actually have to be in that building to do. You know, all the COVID questions, any other practice, they're dying right now because they're so inundated with COVID questions and protocol questions and exposure questions. They don't get reimbursed for any of that time. And so their answer is to try to turn those into visits, right? And that's reasonable because they have to cover their overhead. You know, they've got massive overheads and they need to cover that overhead. They can't just sit on the phone, you know, putting out fires all day. But for me, I don't have to worry about that because my overhead is not based on how many people I run through my clinic. My overhead is based on, or my expenses or my profits are based on how many people sign up for my practice, right? So for me, you know, fielding COVID questions via text, you know, I field enough of them now that I have quick text, you know, macros that I can say, hey, these are the links to the CDC site, these are the protocols, and you know, and additionally, I know this person has her parents living next door to her, and she also has kids in daycare, so I kind of know what their exposures are, and I know how likely it is that they can quarantine or how realistic it is they can quarantine. So I'm able to give them really quick advice, and it makes it a lot less painless. But I guess to answer your question, you know, it hasn't been as much of an issue for me. I have smaller volumes, so I'm able to keep up with my PPE if I need it. If I think there's any suspicion at all that someone's had an exposure, I do a telemedicine, or, you know, I've gone and seen people in the car a couple of times. I try not to do that too much because I get a lot of sidewise looks from people on the sidewalk when I put my PPE on and walk out of the car to swab someone. But and you know, and I will say too that our community has been great in their response of testing. I mean, the hospital is a great resource for getting people in for testing. So I try very hard not to test people in the clinic or bring people into the clinic if I can at all help it. We have lots of other resources that are much more safe in regards to testing.
Oh, that's awesome. That's awesome. And so then, has there been any government assistance throughout your small business journey, or has it just been mostly red tape to work with, or what has that experience been like especially for medical? Like, I always hear medical highly regulated is the synonym I hear in my mind.
Well, so, you know, my biggest expenses are my employees and my rent. And so, and then I do have several, I have I have an Idaho and a Washington license. I have my American Board of Family Medicine. I have various fees and dues that I pay. And then I've got just a slew of accounts that I've opened up for ordering medications and products and whatnot. I mean, I had to purchase a password manager. I have 130 passwords in my password manager now. So there is a lot to juggle. You know, I had to learn how to use spreadsheets for accounting. But for the most part, that's all been kind of fun. As far as your question about government assistance, I actually haven't qualified for any government assistance because my business became a business in April, and unless you were open in February of last year, you don't qualify for any of the grants or PPE loans, professional payroll protection loans. So we haven't had any government assistance there. We were able to procure a small grant for a vaccine fridge through a private, independent nonprofit organization. So that was helpful because vaccines are very much a big administrative burden and time consuming and do not add much to your practice other than for the greater good, which is very important to me. But they really are, a time consuming and administrative time consuming problem or time consuming factor.
Yeah. Interesting. And so then have there been permitting things with your building or licensing things that you've had to do with your space at all?
Yes. I mean, it's all like once it's done, you don't think about it anymore. But yeah, there were some painful bumps along the road. I think I gave myself a 6-month timeline for, from the inception of the business to the opening date. And I kind of had my things lined up that I was going to do at each moment. I think my space was already leased, the place that I'm leasing was already zoned in such a way that I didn't have to necessarily have a different permit for running a medical practice out of there. I have the usual OSHA requirements and but no other special permits.
Okay. Mm-mm. Interesting. And then, is there anything unique with COVID that you're seeing DPC people or those who are running the models, including yourself, pivoting into COVID or pivoting your services? Like, it actually sounds like you guys are making all the right medical industry pivots, like telehealth and that providing better care, better access to specialists. I think your business model is almost perfect in a COVID situation where there's a high degree of trust needed. So it sounds like you guys are already doing amazing. But is there anything specific that you're seeing other DPC models do really well in COVID?
Well, no, I think to your point, like a lot of the things that DPC has already figured out, now the rest of the medical industry is trying to catch up because of the strain of COVID, right? I mean, that telemedicine access, that trying to figure out ways to get compensated. This has been going on for decades, trying to figure out ways to get compensated for preventative services and value rather than procedures performed. There's just so many things against that kind of reimbursement system that it kind of takes these small independent practices that are willing to take the risk to start something new. I don't think there's anything else beyond what we've already discussed.
No, that's great. And so then you said that like you're able to text with your clients. Are you doing a lot of social media, email marketing, and text messaging? Like tell me about that. Like, because we run a marketing company. We know that that's a lot of time and effort.
Yeah.
What has that communication frequency been like?
Well, essentially people have my cell phone number, right? So they get to decide how they want to contact me. And it's a little daunting at first, especially after years of having a full practice, a closed practice, and just to say, hey, anybody that's in my practice can reach me however they want, whenever they want. But the reality is people are generally very logical and respectful about how they use your time. At least so far, I haven't had any trouble. But the times that people text me, it makes perfect sense. Like, I've written a prescription, they've gone to the pharmacy, the prescription isn't quite what they expected, and they're like, "Is this right? Is this how I'm supposed to be taking this?" And they send me a picture, and I say, "Oh, the pharmacist made a mistake. We need to fix that prescription." So really, just like the most efficient way to contact people these days is texting. Like, I don't know how many people you have to call in your line of work, but when I try to call my patients to give them their lab results, nobody answers their phone. So then I'm leaving them a message, and then they're calling me, and they're getting my front office who maybe routes it to my nurse. Maybe the nurse tries to take the call. Maybe the patient feels satisfied. Maybe they don't. And so it's just much more efficient for people to be able to call or text me most of the time. And if there's something that maybe isn't amenable to texting, I can say, hey, let's turn this into a phone call, or hey, let me put you on the schedule for a 15-minute phone call. This is gonna be more efficient in this case to just make the call. So I'm able to make that determination pretty easily.
Ah, I love that. I love it. Our policy is if a email is like more than 5 sentences long, we try to pick up the phone.
Yeah, absolutely. Yeah.
Just because there can be some context lost, and sometimes it's just nice to talk to, especially during COVID, just to talk and hear somebody's voice.
Yeah.
Like that's been probably my most used phrase of 2020 and 2021 of, wow, it is just good to hear your voice. How are you?
Yeah, and same thing with having people come into the clinic. I mean, I feel so fortunate to be in a line of work where I wasn't shut down because I wasn't, I'm an essential worker essentially, and I feel really privileged that I was able to have people continue to see me in my clinic. And I think people feel that way too, right? I mean, I have several elderly patients who I'm the only human they have any contact with.
Sure.
And so, yeah, so I think the nice thing is to have the freedom though, right? The freedom to say, okay, text makes sense for this problem. It doesn't make sense for this problem. It makes more sense to have this person come in and to have that freedom to do that.
Yeah, yeah, and this is just for I'm curious on it. Do you use a special software for like HIPAA compliance, or is there like what does that look like?
We're sort of HIPAA compliant-ish in our clinic. We because we don't bill insurance, we don't technically fall under HIPAA rules, and so we do still strive to use HIPAA. We have HIPAA compliant faxing and HIPAA compliant communication, but when it comes to texting in particular, that's not a HIPAA compliant platform, and so we explain that to patients up front. We say, we let you be the driver in this. If you want to send pictures or questions that are medically related, that's up to your level of comfort, but it is not a HIPAA compliant platform. So we just make sure people know that, and so far I haven't had a single person not want that option of being able to text me. And I think the reality is the risks of that being used against you in some way are basically nothing. So, that's kind of one of those areas where it's nice just to use rational common sense, and we want to take every precaution that we can. We want to make sure we're not sending faxes via non-secure format. We want to make sure, that insurance companies aren't getting, some diagnosis code that the patient doesn't want them to have, et cetera. But if anything, we are, because we don't bill insurances, people actually have more confidentiality in our clinic. So if you have a 24-year-old who's on their parents' health insurance and they want to see you for a problem they may not want do you want to see that screening for venereal disease diagnosis on your insurance? Lots of people opt out of screening for that just because they don't want their parents to see that code on their insurance bill. And so this allows us to be completely confidential for all sorts of treatment options.
Yeah. No, that's fascinating. I wouldn't have thought about that. That's amazing. So then, how has social media and the community been? Like, has that been has it been warm reception, or is there still some confusion that kind of goes with educating people on this newer model? Because we're so programmed to believe, hey, insurance is the way to go. You get the big job or the government job to get the insurance. What has that reception been like? Yeah,
so this is still the most common misunderstanding that I hear from people, or people call and they they see the prices on the website and they say that's pretty great, but I have health insurance. Like why would I sign up for this clinic if I had health? And I don't often say this to people. But what I think is, great, you have good health insurance. Don't let that get in the way of good health care.
Wow. Yeah.
And I think that's often what's happening for people, right? They're rationing their care, not wanting to use their deductible, or they're looking for things their insurance covers rather than things that might be more effective for them. But the reality is, yes, you should have health insurance. You should have that for those catastrophes. But I think in 2019 we spent about $12,000 per person per year in the U.S. on healthcare. So $12,000 per individual. And in my clinic, I charge, anywhere from $20 a month for kids to $100 a month for people 65 and older. So there's an age-based tier. So at most, you're paying $1,200 a year for your primary health care. And study after study shows that you can do 80 to 90% of your health care in your primary care office. So 80 to 90% of your care can be covered with a tenth of what we're paying for our overall health expenditure in the United States right now. And there's all kinds of reasons for that, but the bottom line is it's a very affordable way to get a lot of things done in a very practical manner.
Yeah. No, I just can't get over how amazing the model is. And I love what you're saying about the value of care that is being provided. That is something that just, I don't know that we can always put a monetary value on having a primary care professional that legitimately cares, that isn't just trying to cycle to the next person in 15 minutes. And that's the quality of life that I think a lot of us are seeking and looking for.
Well, and I will say, I mean, you actually can put a monetary value on that. I mean, people are doing that. I mean, you're right. There's tremendous value in that doctor-patient relationship, but there's also monetary value in that. And, you know, there are pilot programs. Q Alliance in Seattle is one. There are other DPC practices who, when they work with employers who have self-insured programs, they're able to show 20 to 40% cost savings in year one just by using a DPC practice. And the reason is because people go to that DPC doctor because they can get in and because they trust them. And that DPC doctor is able to explain things as far as, you know, why maybe referring to an orthopedic surgeon for a lumbar surgery right now isn't going to give you a better outcome, you know, showing them that, you know, taking the time to showing them the study. And so by giving people better accessibility to a knowledgeable doctor, they're not going to end up in the emergency room. They're not going to end up having an unnecessary back surgery. So time and time again, there's more and more studies out there that show that people really do save quite a bit of money by coupling DPC practices with the right kind of health insurance plan.
Yeah. And so then, and there are a couple of really good questions in the chat. I do want to ask real quick though for businesses, as you said, small businesses, do you see this as a good practical option for small businesses to provide some sort of care for their employees?
For sure, yeah. And I think we have 4 small businesses signed up right now, so we do have a few. And you know, the issue for us is we're still relatively small, right? So if it was a really large business, we'd have to be cautious with that because we don't want to live and die by a single business. But the fact that, you know, is this a valuable thing for a business? Absolutely. I mean, my business price right now it's $55 to $65 a month, and it's amazing the value people get for that money. You know, I trained as a rural physician. That was my calling in medical school. I love practicing rural medicine. I worked in Nebraska for about 7 years. And as such, I had to do everything, right? I mean, I took care of ranchers that didn't want to drive 75 miles to the next tertiary care facility. There were no other specialists in the town. It was just family doctors. So I covered the ER, nursing home, hospital, did deliveries. So I can handle a lot of things. So, you know, people are sometimes surprised, like, oh, you can remove this skin thing, great. Or, you know, you can sew up these lacerations, or you can splint this brain. Of course, yeah, those are kind of basic bread and butter family medicine skills that I think most of us have, but we don't always have the opportunity to use because we're so crunched for time.
Yeah. And so then I know we do live in kind of a transient community. And so one of the questions that was brought up was, you know, what if a patient relocates? Do you usually retain those clients, or like what's that experience like?
Well, I'm only 5 months into this, and so far we've had very few people leave the practice, and when they have, it's usually something like, you know, moving. So we don't have much of a churn rate yet, although we're still in the growth phase. But I would say, so if they're in Washington State, we're still able to take care of them as long as they'd like. But you know, practically speaking, you probably want to have the option to see your doctor in person at least from time to time. So you can do telemedicine for a lot of things, but you know, your annual physical needs to be in person, right? I haven't figured out how to do a breast exam virtually. So I think the practical reality is that most people, if they relocate, are probably going to find a new clinic.
Yeah. But I like what you're saying though, and having that option of, you know, say someone does relocate to Tri-Cities or something, and you know, maybe like a 1 or 2 month, like, hey, I still need some telehealth support while I figure out this new area. Like, it's not just an immediate break. It's just, hey, we're here to support you.
Right.
Yeah. So then Marie asked, how many clients or patients do you currently have, and how many do you think is the limit, especially considering the space that you're in?
So to give you some varying on numbers. So my previous clinic, I had about 2,700 patients, and it's not uncommon for a primary care doctor to have a panel of 2,500, 3,000. I currently have 150 patients with the goal of around 350 total. With the kind of medicine I like to practice and taking a little more time and doing a little more, I'll have a smaller panel than some other doctors. I think other DPC doctors, I think they kind of think of themselves as maxing out around 650, 750, maybe 800 patients, depending on what kind of ancillary staff they've got. So, maybe a third that you might normally see in a traditional model.
Wow. That's incredible. That's absolutely incredible. Yeah. And I love your location. Like, I think that's down at the Armory, I think that's it's a beautiful space. I really like that, but I think the renovations have been fantastic. Because I know the building has just changed a lot.
Yeah, it's I have about 600 square foot space, and it's just me. I have one assistant. She currently is working virtually, but she's actually relocating to Pullman next month, which is really exciting. Really bright, really thoughtful, hardworking, great asset to the community. So she'll be relocating and working with me in the clinic there. So that'll kind of change the dynamic a little bit as far as it being two people instead of one. But it's really nice. I don't really have much of a waiting room per se, but the Armory itself has a large waiting area. So on those occasions where someone has to wait, there's a comfortable spot. But the reality is, people don't have to wait very often. When you've got a 30 or 60-minute appointment and you're not double booking people, it's much less common for people to end up waiting. And, I'll give you another example of kind of the blessing of being in this kind of practice, but I did have a patient run long, new patient who, had lots of things that needed to be addressed. And my second patient showed up and she wanted, she needed a urine test for a bladder infection. And so I was able to sort of excuse myself, get the other person, get their urine sample going. And it takes 10 minutes to run a urine sample anyway, and I've got to spin it down in the centrifuge. So I said, hey, you can wait in the lobby, or you can take a walk. You can go downstairs and get a smoothie. I'll text you when your urine sample's done, right? So she was able to go do whatever she did for 15 minutes. And when the timer went off, I texted her and said, hey, it's time to come back up. She came back up. We finished her visit. And I can't really think of a more painless and COVID-friendly way to pass your waiting period than, just being able to go for a walk while you're waiting for your blood sample or your urine sample to spin.
Yeah. No, I love that, because that's a lot of my hesitation. Like, I've been a fan of telehealth for years, just because I'm always leery of sitting in a hospital room or a waiting room with other sick people like that.
Sure.
Even pre-COVID, that just sounds like a not wise idea.
Yeah. Or you're busy, or you don't want to take the time to travel, or you don't want to miss work, right? So these are all things that, again, you can decide. Like, if you enjoy that office visit environment, or you feel like you need to be seen face to face, fine. But there are so many things that you can do on the phone that we kind of force people to come in for. Most things mental health I can do on the phone or do via telemedicine very easily.
Yeah. And so then you said you're kind of around that 150 mark. What kind of things did you do to kind of build up to that? Like, I know you had mentioned before that people had kind of followed you from your previous practice a bit, but were there other initiatives that you did to kind of bolster that?
Well, the reality is I haven't done much, and I haven't done as much as I would have if we hadn't had a pandemic hit, right? I think for people to get the value of this model, you really have to explain it to them. It's very hard for people to look at a monthly membership fee and feel like they want to pay that on top of what they're already paying for healthcare. It really takes some explanation for them to understand, yeah, you're going to pay a little more, but you're going to save a lot on the back end. So it's really hard to just expect people to come find you in that case. And unfortunately for me, I have had a non-compete. I wasn't able to tell my patients where I was going unless they expressly asked me. And so, I think that was harmful to me. But basically, I did tell the patients that asked me, and I started a Facebook page, something that I generally try to avoid at all costs, but I admit it has a reach, it has a value. So I've maintained my Facebook page. I try to put, various types of information up there, whether it's motivational or access or COVID related. And really it's just word of mouth, like just trying to provide the best level of care that I can to the patients that are signed up, and then they tell their friend who tells their friend, and that's been how our practice has grown. So, and I think I think this is about that volume of patients where I have enough patients where we're starting to grow a little more quickly, right? That, when that patient tells this patient tells that patient, it's starting to grow a little bit quicker. And that's been about the right pace for us, given that I have 3 kids at home and I have a husband who's also in healthcare, who's working 50% more than he did previously, and just all those things are all navigating with COVID. So it's been an okay level of growth for us, but yeah, I do think the ways COVID has affected me, the primary way is just I haven't really had the time or bandwidth to market. Instead, I'm putting all my energy into just providing a good product.
Right. And you just bought a new device to be able to test for asthma, I believe, right? Yeah.
So this is another area where it's pretty amazing the kind of technology that's out there for medical devices. And, most things medical device are marked up in an unrealistic way, but it's been kind of fun to shop around for things you can get for value. So we've got a point of care ultrasound that gives me great images that interfaces with my iPad. So, rather than spending $50,000, $100,000 on an ultrasound, I spend $2,500 on an ultrasound.
Wow.
Yeah, and so we recently bought a spirometer, which is a really basic machine, honestly, that I was flabbergasted to hear the hospital was charging $1,000 to do spirometry for a cash pay patient, and I'm able to buy the top of the line spirometer for that exact same money. We have all the instruments we need for minor procedures. We have electrocautery, so we can do derm procedures. I've removed a couple of small skin cancers already. So we've got all the kind of machinery we need to do all the kind of basic in-office procedures that you might think a family practitioner can do. And we're able to buy them in compact sizes, right? Because this is we're in an era where technology, the advancements in technology allow us to have these, small cameras for doing colposcopy or small spirometers. So I'm able to fit all this equipment into my tiny little space, and it's user-friendly and interfaces with my iPad, and it's great.
I love it. There's a lot here. There's absolutely a lot here. And it's just, like, I keep saying, wow, that's incredible this whole time, because charging $1,000 for a fairly simple test, like, that's
simple,
incredible.
Not new technology, yeah.
And I had no idea the ultrasound machine looks large, and it's cool. I mean, you get to see a baby pop up on those, like, I think that's amazing.
It's amazing, yeah.
But then if you're able to do something for a percent of the true cost, like, oh my gosh, that's mind-blowing.
Yeah, I mean, this is one of the things that actually got me interested in DPC, is this realization that in every other technologically touched industry, technology reduces prices, right? Yeah. I mean, look at cell phone prices. I mean, cell phone prices that are at a point now where literally everybody and their kid can afford one. And, we think in medicine that our healthcare prices are high because we have the best technology, we have the best care, and it's not true. I mean, when our technology improves, it should actually bring down the price of care, but that's not what's happened, and there's a lot of reasons for that we can go into, but the basics of it is it has to do with malaligned incentives, right? I mean, the things that we make money for are the things that we do, and the price inflation is supported by various factors in terms of kickbacks or non-transparent pricing, et cetera. But what I learned, one of the first things that piqued my knowledge about DPC was learning that there are places where you can get an MRI for $300. And in my mind, I'm always used to thinking MRI is always done for surgical planning, right? I'm constantly trying to talk people how to do an MRIs, because the only utility of a test is if it's going to change your management. If you're thinking about surgical planning for that knee or that back, then an MRI is reasonable, but you're going to pay for it. It's going to be $3,500. And then to learn that there are places that are charging charging cash prices $300, $400 for an MRI. Similarly with the labs I order, right? It's very, I don't ever expect to order a lab panel without that patient paying $200, $400, $500, maybe $1,500 if we're looking for more unusual diseases. In my clinic, the most expensive lab panel I've drawn so far is $300, and that was a very extensive workup. I mean, my CBCs are $5, $6, my lipid panels are less than $10, my chemistry panels are less than $10. That's the real price of those labs. There's so much price inflation in medicine right now, and we just take it for granted. And, they charge it because the market will bear it, but there's becoming an increasing segment of the population that isn't bearing it anymore, right? I mean, we have the working poor, we have people with high deductibles, we have people that are rationing their own health care so that their kids can get care. And at some point that's going to break, right? And that whole idea of providing preventative services to reduce our costs down the line is failing those people.
Yeah. No, that's incredible. My dad's done a lot of MRIs lately, so I'm like, oh my gosh, $300 for an MRI? Oh my goodness, that's...
Yeah, I had the same reaction.
Shaking his head, Marie's shaking her head like, this is absolutely incredible.
I want to make one more point, which I think, I don't know if people find this to be of value to them, but I think they should, and that is that people are frustrated with their interactions with the healthcare world, but I don't know if they realize how frustrated their primary care physicians are and how burned out this is an epidemic that is well known in the medical community, but I don't know if people at large understand this epidemic. And we have, highly trained, highly motivated, intelligent people who are leaving the profession in droves because they're tired of being that hamster on a wheel. They're tired of being a referral monkey. They're tired of not having autonomy. More and more practices are being bought out by organizations. Doctors are losing their autonomy. And what people value in their medical practices, they value that doctor-patient relationship. And so the more things that are put in between that doctor and that patient, the more barriers, all those things that frustrate you when you're trying to get into your doctor, those frustrate your doctor too. Only we do it every day, right? We do it 12 hours a day. And so you can imagine that thing that you have to sort of say, oh, is this worth me going to endure this system for? That's the system we're in 12 hours a day. And I think people don't recognize that doctors are choosing administrative roles. Doctors are choosing to retire early. Doctors are choosing to go into completely different professions. And, in their place, we either have less, shortages, or we have non-physician medical practitioners who may have less than 1/10 of their training. I mean, literally, some nurse practitioner doctorate programs have 50 hours of training, whereas in medical school residents, you have 15,000 hours of training. So 500 versus 15,000. That's the number of hours difference between an online nursing doctorate versus a fully trained physician. And I think, I think we hear this over and over again that we don't value our primary care, we don't value our preventative services, and I feel like that's one piece of it that people need to be aware of, is that those people, they're in the trenches, those people that you're frustrated because they're not getting you their vaccine, or you're frustrated they're not taking your COVID call, they're frustrated too, right? And they're part of that system too. So I don't know that I should for that, but I feel like it's a problem that people should be aware of.
Well, thank you so much, Dr. Jones, for all your time here today and for being here. And I do want to once again thank the Southeastern Washington Economic Development Association, the Pullman Chamber of Commerce, and of course the SBDC with Aziz Makhani. They're such amazing resources that we get to have on the Palouse that help promote these and advertise these, and we'll get the recording out as soon as possible. Thank you everyone for coming today, and drive safe. Hopefully don't drive. Take care.